So you have to look at the ampullary morphology, and then also the number of the size of the stone in the duct is also important. If you've got, sometimes you've got a big ampullary morphology, you've got a bulged ampulla, and then if you want to size the sphincterotomy, you can go till the end here, but sometimes you'll not know that is the end of the duodenum, so you have to reassess it. Chota sphincterotomy kariye, then you take your sphincterotome inside, half bow, or if you pull it, then you'll know exactly, again, it will come in the line of the duct, then it will help you to assess how much more you have got to cut. So it's about reassessment. Just initially, आपको समझ में नहीं आएगा कि what is the limit of the sphincterotomy. But again, even if you've got a large ampulla, you don't have to cut, it's not necessary that you have to cut all the way up. It depends on the size of the stone in the duct. अगर छोटी stone है, what is the need to cut all the way up? There's no need for it. So that again comes with experience. So first is understanding the morphology of the ampulla, what is the limit you can cut, and what is the size of the duct. But size of the stone in the duct. Agar stone itna, like we saw, there's a big stone, then you have to do a generous sphincterotomy. Then it's important to know what is the limit of the of your infundibulum.
We are going for sphinctoplasty, then we have to do generous sphincterotomy.
No, then it's not necessary. Yeah, then you can do a small sphincterotomies, and if you really know that from the beginning that you're going to do a sphinctoplasty. But agar if you've done it, sometimes it's difficult to know, but you think that with this sphincterotomy you'll be able to take the stone out, but then you're not able to, and then you want to do a sphincteroplasty, that's also okay. So for a plastic stent, again, it's a bit debatable as well. So whether you do, again, some people do a small sphincterotomy and then do a stent, so that the pressure on from the stent doesn't press on the pancreatic duct, so that it doesn't cause pancreatitis, is one of the theories. Yeah, so I think, but then some of the, you will do a small sphincterotomy and then put a stent in. Yeah. Yes, so especially in there's most of the time, again, clinically, in a sense, the patient is jaundice, painless jaundice, and if elderly patients, or you're seeing a stricture in the lower end, and then CT, MRI will also be helpful. It's not difficult. So you know that you're dealing with a malignant stricture. Again, benign strictures on its own is very, very. What are the causes of benign strictures? Benign strictures are mainly stone related. So there's a stone related inflammation, or if it's a chronic pancreatitis related inflammation, which causes the strictures. Again, autoimmune cholangiopathy doesn't cause a significant stricture like that. So you know, most of the times you're coming across strictures is related to the malignant stricture. But again, if you're not very sure, then again putting a plastic rather than putting a metal stent in our, again, that is not we will advocate for you. In a sense, plastic stent is enough, good enough for in those situations in your centers, cost-wise. But again, in Western practice, it has just, we have moved on towards fully covered metal stenting when we are not sure what we are dealing with at that time. But plastic stents is good enough.
And then when do you remove it? When do you remove it if you find it is a benign structure?
Yeah.
How much time did you give them?
Normally we give about 2 to 3 months time. So yeah, so
It remains there for
3 months. Yeah.
Can you take it easily?
Take it out and then yeah, fully covered. Fully covered comes out. Even we can leave it actually for 6 months as well. It will come out. But if you have left it, we have found that when you have left it for more than a year, is when we have seen that when we try to take it out, those the mesh of the stent they disintegrate. So we had one patient which was there for more than 2 years, and then when we had tried to take it, we had to take each mesh out one by one because it just opened up like this. So trying to take it out, we had to take one fiber by fiber. We had to take it out. Okay. You mean sphincteroplasty? No, that.
I want to ask if you find a distal benign structure.
Okay.
And
sphincteroplast is not the right way to do it. The risk of perforation is higher. If there's a stone, if you got that in a scenario like this, when you've got a stone-related stricture, so there's a stone here, and then there's a stricture here, and these are the ones suitable more for a spy. These are the situations. Or when sometimes you have, if there's a stone on the top here, and then there's a stricture below that, and you can sometimes use, these are when there's a definite stricture, those are the ones which definitely you go for spy.
कैसे आर यू लाइव? ठीक है जी। तो बेटा वो ज़रा केस डिस्क्रिप्शन बता
आवाज़ आ रही है? अस्सलाम वालेकुम, आवाज़ आ रही है नवल?
There's a benign stricture, stone related, or if it's autoimmune or a chronic pancreatitis, you don't need to dilate the stricture. You can just put a stenting and then come back again, and then
उनका नहीं है, मतलब हमें सेमिनार रूम नहीं नज़र आ रहा।
आवाज़ आ रही है आप लोग को? वो होना चाहिए इंटरेक्शन ना कि हाँ कि कौन सवाल पूछता है, कोई क्या कर रहा है। बेटा ज़रा इधर, लेकिन यहाँ पे ताकि हमें पता नहीं लग रहा ना कि किससे बात कर रहे हैं। यहाँ पे स्क्रीन पे जाए तो अच्छा होगा।